1.7 million primary hip replacements have been recorded in the UK. This is 2024 stats. Okay. So it's, I mean, we are in a different world now compared to what you were looking at 20 or 30 or 40 years back. And therefore, I think radiologist will come across, some patient with prosthesis and in the pelvis or in the shoulder. Knee prosthesis is also quite evident. Now they have started doing ankle prosthesis as well. So the other point is the revision rate is also expected to increase. So the revision rate is, what are the three main causes for revision? Top three causes are, first is aseptic loosening. So 27.8% of the patients will have it for that indication. The next one is infection, and then next is dislocation. So dislocation, to a certain extent, it is, quite evident on the plain radiograph. But these two, this also infection, maybe if it is very acute, they may present with raised inflammatory markers and acute pain. But aseptic loosening, which is the highest, one of the highest reasons for the revision, will be something that we as radiologists will be able to pick up and help the surgeons identify this. So this is the background of why I think every radiologist should be able to interpret any imaging, especially the plain film we'll start off with, because that is something that everybody, it's like bread and butter for every radiologist. And some hospitals before, it used to be that all the post-op, imaging for post processes will be auto-reported, and many trusts now, in UK will also have some of them an outpatient will also be, just not seen by the radiologist because the surgeons will be looking. But more and more patients are having these, and therefore they'll come through GP. They may come just as ED patients, or they may come via some other mechanism in the hospital itself, and they come for PUO. There's so many causes that you can think of, and so many unusual presentations that they can come with. But if you are aware of the processes and what their imaging is, what the findings are, what are you looking for, I'm sure you'll be able to help these patients. So looking at, we will go through whether, these are different things, and, there's a lot of jargon, and you think, oh my God, I'm not going to, get through this, and what does this mean? What are the different things? So we'll just break it down into what does it mean? Because some of the complications are associated with some types of, hip processes. Therefore, knowing what kind of hip processes there will be good. And I encourage my residents that, when you're reporting, just don't say there's a prosthesis in situ. Try and say, is it total hip replacement? Is it, cemented? The more you use these terms, the more familiar you become, and then you're not going to fear them. Okay, so we're going to try and build that in, but then we will look at cases to see how we can use different imaging. So first is non-cemented. Okay, so this is easy in the sense you can see there's absolutely no cement used here, and this is a patient with cemented thing. So when do you use and which one do you use? That's also important to know, because if you see, the cemented ones are used in slightly younger patients with healthier bones, that is, they're not osteoporotic, because they need to heal, and that's how the stem will get fixed into the bone in these patients. But it's important to also note that they will have a subtle lucency around them, because that is one of the findings that we are looking for. Is there any lucency around the processes that will help you decide whether there is loosening? Okay, so this will be less than 2 millimeter. It will be quite uniform all around the processes. So this is the ingrowth that we see in a uncemented processes, especially around the stem. The other thing is, when they are getting fixed, they can have increased intraoperative fracture risk because it has to be really tight. They don't make a bigger hole and then fill it with cement. Yeah, so it has to be a very fit. So it's called press fit. So when they're doing that, you can have periprosthetic or intraoperative fractures. So those are the complications that you're looking for. But the good thing is they have better long-term bond and decreased revision rate. Okay, so these are the advantages of having a non-cemented press fit prosthesis. Whereas some patients, because of some factors, like they may have previous tumor and therefore it's irradiated bone that they have, or it may be because of obesity, that is a habitus, or the bone density itself, that's osteoporosis. And in these patients, because they cannot heal very well, they will have a cemented prosthesis. And this is the high attenuation that you can see, and this is the the blue arrow that you can identify. Let me see whether I can use the uh, drawing tools. Is it? Yeah, so pen. Okay, fine. So that's the blue arrows that you can see. So, and this one, it has definitely lower intraoperative fracture rate, and they can go to weight bearing quickly, and they can be reduction pain quickly. But the cement can degrade, and it can cause inflammatory reaction, it can cause loosening, and that's why you can get osteolysis around it. Okay, and sometimes you get lucency at the bone and cement interface. So that is acceptable, the bone and cement interface. So this is like a little bit of quiz kind of a thing, an interactive thing. It's no use you being passively listening to me. So I want you to make a note, or put it in the chat. What kind of hip replacement are we looking at here? So it cannot be just hip prosthesis in situ. You have to say da 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 da. So I want you to use the terms that we said: cemented, uncemented, unipolar, bipolar, and hemi or total hip replacement. Those are the terms that we will be using. So I'm thinking that you all are doing some thinking and writing down your answers. I can't see the chat, but the answer for this will be cemented, unipolar, hemiarthroplasty. Why hemiarthroplasty? Because that is the native acetabulum. Okay, that's just the femoral head. So, and then you can see the femoral head is the stem is fixed. That's the the arrowheads that's showing, and it articulates with the acetabulum. So that's the hemi. Okay, and it's unipolar. So it's all this is one unit. The next one, again, think about it. So this time it'll be easier for you, because what native acetabulum will look, so it's a hemi. But the difference on this time will be it is a bipolar. What do you mean by bipolar? That means the femoral stem, this is the stem of the thing, it articulates with a polyethylene lined middle cup, which articulates with the native acetabulum. Okay, so this is a cementless bipolar hemiarthroplasty. Okay, then you're going into, again, I mean, this you'll recognize, you start recognizing the hemis very easily. So you have a native acetabulum, that means there is no, the acetabulum is not being replaced, and this is resurfacing. So only the femoral head is being replaced, which articulates with the native acetabulum. Now you also can get a, so the next one, this time you'll recognize this better. So you are having a cementless total hip arthroplasty. So no cement. So you can see it's the, that press fit kind of a prosthesis, and it's having the femoral head, and then it's having the acetabular component. Okay, so it has a femoral component and it has a acetabular component. So the open arrow indicates the polyethylene cup at the articulation of the prosthesis and the acetabular component. This is the liner, the polyethylene cup that articulates. Okay, so these components are important because there are complications associated with these components, and that's why, we just need to reiterate and revisit. Okay, what are the different parts, and is it hemi, is it total, is it cemented, is it non-cement? Okay, and this one here, you will know this now because it is cementless resurfacing of, and it's total because you have both the femoral head and then you have the acetabular. Okay, so it's metal on metal. So this is the one, and you'll start thinking, I know this metal on metal, the complications that you get, but you also can get complications of metal on poly. Okay, so on poly, so you do get complications with others, but metal on metal, the reactions that you get and the complications that you get is better known than the other ones. So we have looked at hemiarthroplasty. Okay, we have looked at resurfacing, we have looked at total arthroplasty. This is another one. So this is when all this fails and you have to get the revision done. Okay, so hemiarthroplasty, just to revise, so all the three cases, when we saw whether it's unipolar, bipolar, or resurfacing, there's a native healthy acetabulum that you can see. Okay, and like I said, it can be unipolar, bipolar, and the bipolar, it depends on whether it's a inner head, larger outer head, and it also what it main thing causes is native articular erosion because you have a native acetabulum. Then resurfacing also, we said it can be complete or it can be hemi. The disadvantage includes the femoral neck fracture, because you saw in the femoral neck you have a very thin component, so it can cause fractures of that. And then total, you have seen it's the acetabulum is also reamed and both the femoral and the acetabular components are inserted. Okay, and we have looked at arthroplasty. We said, what are the indications? We said aseptic loosening, osteolysis, aseptic loosening, dislocations, infections. Okay, the other ones are the polyethylene wear and the fracture of the polyethylene. Okay, and also if you get ceramic, it can also fracture. So that's the thing we were talking about, different components that we have within the hip joint, the hip replacement or the prosthesis that can be subjected to various kinds of wears, especially because they are going to be there longer because of longevity and because of aging population. So these are the different examples, so it's native acetabulum, and then you have the resurfacing, then you have the total, and this is what the revised prosthesis looks like. Okay, so it's very different from the total hip arthroplasty that you have seen. Okay, so this is the same thing with showing all the different components, and we have looked at it with different individual examples as well. So you have to keep these terms in mind as we go through the cases now. Okay, so first thing is metal on poly. So what do you mean by this? Yeah, the metal is the femoral head and the liner, so that otherwise, if it doesn't have anything to um, put the forces against, it's going to make like metal on metal, like it'll make sound every time, right? So the liner is a polyethylene liner. Okay, it's important because you will have a radiolucent space between the acetabular and the femoral components. Okay, so I mean, when you're looking for lucency, you're looking for lucency around, and this is some lucency that you will be able to see and you should see when they have a polyethylene liner. Now, this is more prone to osteolysis compared to metal on metal or ceramic on ceramic prosthesis. Okay, and the other important thing is there's high risk of impingement and dislocation. Yeah, so these are the disadvantages and these are the things that you will look for when you look when you see that the patient has a polyethylene spacer. So let's look at the what are the different things, and what are the where's the polyethylene liner here. Okay, so you have the head itself. Okay, so the stem, then you have the head, and then this loosened thing here, between the acetabulum and the femur there. Okay, that's the acetabular component. That is the polyethylene liner that you're getting. And you can also get, like, if I go back to this is metal. Okay, and then you have the polyethylene liner, then you have metal, whereas this one is ceramic. So you can see this component through that, right? You can see the femoral, the neck through that head. That's because it's ceramic. Whereas if I go back here, see, you can't see that because it's metal. Okay, so I just want to show you the difference between the ceramic head and the metallic head. So this is, again, you're going to describe it. So cementless total hip arthroplasty, and it's ceramic on poly. So, and we said metal on metal. So metal ball, cup, it's directly in contact. And the larger head, it reduces the dislocation and impingement. But the wear and corrosive occur when metal on metal, the direct contact occurs. Okay, and this is the one that we had a MHRA. I think it was 2012 or something like that. There was a notice, and the British Orthopedic Society and the trust and MHRA, they had to recall many of the patients back, because if they had a big, large femoral head, then they were at high risk of what we call this metallosis, and they can have risk of skin rash, cardiomyopathy, neurological changes, and many other changes that did this one. So many of them were recalled to address this issue. So now we'll go to first case. So 70-year-old female, and the right hip gave away in shower, and the right THR had been done. Okay. So this is a radiograph about I think 10 years when the right THR was first done, and this is the current presentation. Okay, so this is 10 years. So 10 years between the two radiographs, and there are more serial radiographs in between. Okay, so I just want you to look at what are the changes in the radiograph. What are you seeing on the radiograph? And I want you to think about what we have talked until now about this loosened area that you're getting. Okay, so we talked about the polyliner. So this is the lucency that you're getting. So I mean, the answer is on the plain film. You don't need to say that I need an MR or a CT, to say what the complication is, because many people think plain films are, not very good, and they're low value and easily obtained, so they must not be very good. But plain films are pivotal to diagnosis of many of the periprosthetic complications, including this one. Okay. So can people think about what is happening between the two radiographs? So you must have noticed that it looks very symmetrical, the space around it, whereas this one looks very asymmetrical. Yeah, it's not projectional. See the obturator foramen, it's clean, it's neat. Yeah, so it's not like it's very oblique. Okay, so it's straight on, but this is very asymmetrical. So this is nothing but catastrophic failure, meaning like complete failure. It's not like it's that kind of catastrophe. It's complete failure with of the polyliner, okay, of the right hip. So this, I mean, again, showing you just the radiograph on its own, and this is the bit I was talking about. So look at this compared to this here. Okay, and same thing here, you can see this here is such a large space compared to this here. Okay, so I mean, again, like I said, the answer, though there's no added value for this particular complication with MR, the answer is on serial radiographs. So all you need to do is get the previous radiograph and have a look. Even if you didn't have the previous radiograph, the fact that it's asymmetrical is the clue for you to think about this complication. And the patient went on to have a complete revision of that. So and because it is needed, I mean, it's impossible to have that kind of liner wear, and the patient will have a lot of pain. It'll also, there'll be a squeaking sound every time the patient walks because the liner is worn off. Okay, so that's how the patient may present with pain or with a squeaking sound. So, liner wear, again, just to tell you about the different components. So, like we said, the head can be ceramic or metal. So, I have shown you radiographs of both, how different they look when it is ceramic and how it looks when it is metal. Now, the cup liner can be ceramic or polyethylene. Okay, and that's the bit that we are telling about, that it can wear out more easily. Okay, and then the cup itself can be metal or polyethylene, and it can be cemented or cementless. Okay, same thing with the stem that we said, cemented or cementless. Those are the two combinations. So if you look at this radiograph now with all these components that you can see, so this is the polyethylene. So you can see it looks very lucent. See, it's very lucent. Yeah, so this is the polyethylene, X-ray transparent. Yeah, that's the acetabular cup itself. And we said the polyethylene liner, when it fails, it will cause osteolysis. So these changes you can see. I mean, it's not necessary that any a radiologist who's interpreting the thing will be able to see that there is lucency, which should not be there. Okay. The other thing is why serial radiographs are important is you may have a patient who already has subchondral cystic changes in the acetabulum prior to the hip replacement. So that's why serial radiographs will be helpful. So if you see native hip and there were no changes, but post arthroplasty there are changes, then that has to be osteolysis. You have to think about that. There are a few other areas that you can get, like stress shielding, because of the change in biomechanics you can get. But that kind of very lucent change here, see this here, okay, that is osteolysis. Okay, so so you can see the femoral head, and then you have the polyethylene, and then you have the acetabular cup, and you can see this one. And again, can you see the asymmetry? So this is much larger than this here. Okay, and that's why you have the osteolysis. So the other way of looking at it is you can get what we call a creep. That means it's slowly, it's normal to see thinning in the weight bearing of this one, because it's polyethylene, isn't it? So it's plastic. It'll just mold itself. Okay. So but that will be symmetrical. It'll be symmetrical. Whereas if it's worn out, yeah, it's abnormal loading or to the pressure more laterally, okay, resulting in the wear in the supralateral area. So when we have seen the previous case as well, it was in the supralateral area. So I'm going to go back to that case just to emphasize this. So this area here is where the wear had occurred and there was asymmetry and the femoral head had moved closer to this area. Okay, whereas creep is just generally it is just gone in a little bit. Okay, so I'm just going to go back to that first case we had here. So can you see it's supralateral area that the wear will occur, and therefore the migration of the femoral head is the supralateral area. Okay, fine. So I think we have sort of nailed polyethylene liner wear and what are the findings that you get on plain radiograph and how it looks, and also the fact that just plain radiograph, serial plain radiographs, and review of those is enough. The MR usually doesn't add much to this part of the diagnosis. So we'll go on to case 2. Okay, so this is a patient who's had THR in 2008. He has 18 months of worsening pain in the right groin and hip. Okay, and then there's sudden pain for one day and with a grinding stone. Okay, so he's been having some ongoing pain, like chronic subacute pain, but suddenly one day he stands up and there's a grinding stone a sound and there's a lot of pain. So this is the radiograph for the patient at the time of presentation. Okay, so again we are going to look at what kind of processes this is. So it is a cementless, so there's no cement at all, and this is that 2 millimeter lucency that I was saying that you should find around. Yeah, so that's what you're seeing. Okay, and then it's a total hip because there's no native hip, and you can see the acetabular component, but you can also see that it's a ceramic head because you can see a little bit of the head itself, whereas if it was completely metal you shouldn't be able to see this part of the stem and then see the head also. Yeah, so you can see the stem and the head. That means, remember, we had seen whether it was a ceramic head. Now ceramic head, it's like china, isn't it? Like you throw it or it breaks into pieces. Okay, and that's what has happened here. So I think when this was reported initially, it was reported as maybe artifact, on the patient, which happens sometimes because they come with different clothing and things like that. But this is quite dense and this is multiple, around it. And okay, if you even if you miss that, this is not right. This is not symmetrical. Where is the other part of the head? Why can't you see a nice, rounded thing here rather than so much asymmetry? This is not right. Okay, these things here are not right. Okay, so it'll be amazing if you are not thinking about it. It's very easy to walk past this. Yeah, and you can just compare it to the previous one and say, because you are looking for lucency, you're not looking for density. Yeah, so then you will just say, oh, there's no periprosthetic lucency, it is unchanged from the previous, it's unchanged from the previous. Yes, there is no periprosthetic lucency, and if you look at the prosthesis itself, it looks as if it's well positioned and well fixed. But what is happening, in that area where you should just be able to see a ceramic head is where your answer lies. Okay, it's like when you say the eye sees what the mind seeks, kind of. So if you're looking for lucency, that's you will see that, and you will definitely uh, correctly report that there is no periprosthetic lucency. But that's not the reason for the failure. Okay, let me see whether this works. I don't know whether I need to come out of it. Let me see whether I escape it and then it comes. Yeah, so let me do it like this. You can see the video, I think. So this is a CT scan, and you can see, it's completely in pieces. Okay, so that is the ceramic liner, which is in pieces. There. Okay, there. So it's in pieces. Yeah. So that's what has happened in this case, and that's the complication that you're looking for, and that's why the grinding sound. Can you see again the asymmetry in the femoral head? Because it's all broken, it's going and grinding against the acetabular component. Yeah. So going back again, and you can see multiple fragments, and the orthopods wanted to know where the fragments are and whether they need to fish out any of them, because they can cause local inflammatory response to it. Okay, fine. So we'll go back to the fine. So I think this is worked. Now it's working. I don't know. It seems to be working now. Okay, fine. So let me go back to the thing. So case 3. So that was again the ceramic liner breaking. So case 3 is a patient, and again you have to describe what kind of processes you're seeing. So it is total um, resurfacing that you're seeing on both sides. Okay, but again on with the total resurfacing, most common complication is osteolysis. Okay, so that's what you need to look for. I mean, we said that it can cause fracture of the femoral neck as well, because it's very thin, but lucency is what you're looking for. So if you see here, again, it's very easy to walk past, and people have walked past it, but there is this lucency here that you can see, and I don't like this here as well, and these lucencies here. There's a little bit that you can see here as well, but you see this is different from that kind of lucency that you sometimes see in the stabulum. Okay, and is there anything around in the femoral neck as well? So you are looking for lucency around the processes in these patients. So on the MR, so this is your with experience, I think comes some knowledge as well, and things that you notice is you do Mars sequence, yes, and you do a stir sequence, yes, and usually you think stir sequence is best to look for collections, for tumor like lesions and things like that. But when you're looking for osteolysis, when you're looking for pseudotumors, especially osteolysis, yeah, best seen on T1. Okay, so look at this. You can see it very nicely. So that's the normal marrow, but you can see that there is complete replacement of the normal marrow. So when the surgeon goes in, I went in and saw one of them, and one of the surgeons then, also took post-operative, perioperative or intraoperative pictures, and this is literally like completely lysed. It doesn't have any bony substance at all, like black jelly like thing that is replacing this bone. Okay, so that needs to come out. It's one of those things that cannot stay there anymore, and you can see why the moment you suspect there is going to be any osteolysis, the process needs to come out and replaced, because it just eats up the bone. Okay, so it's locally very aggressive process that will just destroy the bone. So there's no new bone, there's no normal bone texture at all that marrow has been replaced by this tissue. Okay, so you can see it sort of here, but really it's very difficult is what I would say. Okay, but T1, look for T1, look very carefully at T1, and your answer will be there. So again, this is to show you, on the T1 as we go through the images. So you're coming into it. Look, it's extended, all the way to the iliac blade, and there are some changes that you can see in the femur as well, and it extends onto the surface there as well. So, and into the ischium. So it's quite a lot of lysis. And can you see here? See, and it shows very nicely. The T1 shows the demarcated, osteolysis and the normal marrow. It shows very clearly the change in the bones. Yeah. So just try and go back and just pause it there. So you've seen this on this thing, but I just want you to appreciate, Can you see the ischium? Yeah. No, the whole thing is replaced. It's all expanded, and this is very extensive osteolysis. And if I go back, and the MR was not done like years after the plain film. Okay, so the plain film was done. So if I go back to the plain radiograph, this was done, and you can see here the lucency. But if you, it's very easy to walk past as well. You know, if you're not looking for it. What I'm saying is the MR was done about, I think, 5 days, 10 days after this. So it isn't like there's a big time difference. So this whole thing is abnormal. Okay. And we know that, you know, even when you're looking for tumors and things like that, the plain film can underestimate. But what I'm saying is the plain film has given you the clue that there is osteolysis there, and you have to go and investigate. So because that will be the first thing. I mean, we won't be doing MR. You know, the moment patient comes, it will be the plain film that you will do first when they're presenting with pain. So I think this is the yeah, it's the same video, so we can go to the next slide. Yeah, so this is the CT scan on this patient, and again, you know, the you can ask. I mean, all the scanners nowadays are very clever in the sense, like, you know, the technology is very good, and you can have Mars metal artifact reducing sequence for the CT as well, and it really, you know, removes the artifact, and it can show it very nicely. Okay, and you can see complete osteolysis. You can see the soft tissue component, you know, extending outside as well. Same thing, like, you know, how we saw on the MR, it was all expanding the bone and causing quite a lot of lysis. So 3 years ago, you know, this patient had these changes here. Can you see? Okay, but I mean, you can easily walk past. Yeah, retroscope is really good, but I think, you know, hopefully after the session all of you will be thinking, you know, am I looking at the MR scan, am I looking at the T1 weighted images, am I picking up these changes? Okay, so please look out for these changes. I mean, these have to be done with, you know, the mass sequence, but in that also I think you can look for the T1 and look for these changes. So that has become, you know, complete destruction of, you know, the whole of the component. So this is same patient 3 years ago. So then they went on to have, you know, bilateral hip replacements. So again you can say what kind, because it's cementless. It's the press fit. Okay, it's cementless and it's total, and it has a polyliner. Okay, because of this lucency that you can see. Yeah, so similar here, but it's also having reinforced, you know, with the estabular component, because there was so much lysis there. Okay, so that's why they have done, and they have done a little bit of bone grafting here to try and fill that, because of, again, osteolysis that the patient had. Okay, so now going to, you know, these terminologies, and, you know, what are they, what are we looking for? So you would have heard about, you know, IL-valve. It is nothing but type 4 hypersensitivity response. Okay, so that's the response that you're looking for, and that's what causes the soft tissue changes. Yeah, and what happens is you get these tissue deposits. These are nothing but the pseudotumors that we talk about. These are the pseudotumors we talk about. Okay, so so the metal ions from the processes, so they are very, you know, you can measure them. So the hip surgeon will aspirate and send the aspiration for metal ions, or they can check even the bloods for the metal ions, and you're doing the MR, you know, to check for pseudotumors. Before they used to say, you know, use ultrasound and you can see maybe posteriorly, but you'll look posteriorly. But really depends on the habitus of the patient. So I would rather do MR to get a complete picture of, you know, how, where the pseudotumors are. So this is aseptic lymphocyte dominant vasculitis, okay, ALVA. Now, these pseudotumors and metallosis, like I said before, it used to be metal on metal, yeah, but it has been now well described metal on poly or ceramic on poly, okay. So it is not confined to metal on metal. I have seen, quite a few cases. We have a regular arthroplasty MDT every Wednesday, and I think that's one of the best MDTs I like, because I have also learned a lot. You get to see the complications, you get to see what the intraoperative pictures look like, you get to see what are the practical difficulties, though we'd say, oh yeah, that's that needs replaced. What they may face because of the osteolysis, how they can do custom fit processes now. And so yeah, it's really a good learning curve. And when Dr. Khan invited, I thought, okay, this is something that I can share with others as well. So the metallosis. So please, there are two papers, and I think both are radiographics. So the types of hip replacements that we saw, that also is in radiographics and radiology. That's a very good article. And this about metallosis and alval and pseudotumors, and what are the different descriptions and how do you diagnose them. That radiographics article is very good. Okay. So what does the metallosis do? So it initiates a macrophage activation, and it's more osteolysis that you get. So that's what we saw on the resurfacing. The two cases that we saw in the resurfacing. That's metal on metal, and then that caused metallosis. Okay. So osteolysis, which we saw, just now, is more defining characteristic of metallosis. Okay, it can occur in both alval and thing, but it's more defining character of metallosis. So basically, you can have in very prosthetic complication, you can have metallosis, which causes which presents more osteolysis, or you can have alval, which presents more like pseudotumors. So you're looking for these kind of findings when you're looking at the radiographs and the MR. So the radiograph will help you with the osteolysis. It may not help you with the pseudotumors. So unless again it's causing a lot of destruction, that's why it's called pseudotumor. Okay. So I think I have a case of pseudotumor here. Okay, let's see. So this is right hip pain swelling. Okay. So swelling is one of the main presentation for this patient. So he had first presented with left-sided hip pain, yeah, and he had X-ray, MR, and revision of the left hip pain, and then he refused treatment, and then started presenting with dislocations of the right THR, and then he presented because he could not mobilize at all. Okay, and he was a farmer, from what I remember, because I went to the ward to see, how this pseudotumor looks like in this patient, and and they are typical. I mean, in the southwest, like if they are coming to the hospital, that means something really wrong. I mean, it was dislocating, and that's why he came. He didn't come because of pain or anything like that, and he came because there's a big swelling. He can't move. Yeah. So they really are very resilient. Like they don't want to come to the hospital till they can't move or they can't do their work. So this was the first, MR that the patient had. So imaging in 2012 at the initial presentation. So you can again see that this is a cemented, hip processes, and it's total because you have the acetabular component also, but you have poly. Okay, so the acetabular component is, and there's a big poly. Okay, but there's a lot of lucency here, you can see. There's a lot of lucency here as well, you can see. And this around the greater trochanter looks a little bit. This is heterotropic ossification, newborn formation that the patient has. So these changes, if you see here, look, all these changes here, that's not right at all. That looks like, pseudotumor. Look here as well. Okay. So that is as if, there's a soft tissue masses that you can see in this patient. So that's what you're looking for when you're looking for like pseudotumor presentation. Okay. In this case, this here is this change in the T1. That's normal marrow. Okay, these are changes in the T1 on that side. So that he had replacement. Remember, so he did get operated for that. This is the right side that he's come this time. Okay, and you can see why he's getting recurrent dislocation. So this is complete destruction of the right hemipelvis. If you see, it looks very, very destructive. So I remember that it was reported as like a destructive bony lesion, likely metastasis, and could be this one, and the patient went on to have CT, and I was like, no, I mean, this definitely, because you can see the start in the previous radiographs, so this definitely has to be a pseudotumor. So we did an MR, and you can see the low signal intensity outlining the lesion. So this is all the thing. So this is why I went to see the patient, because I wanted to see why was he ignoring and how big this tumor on the thing is. It's a big swelling. You can see it from the end of the bed or end of the room itself, and he waited till he could not walk, to come to the hospital. So this is a very big pseudotumor that the patient has. So if I go to the next one, so yeah, you can see this, and it is eating into the femur as well, which is what it's doing here. It's eating into the acetabulum, and it's eating into the ischium, and it's just mega. It's just big, really big. And if you see, that's what it looked like on the operation theater, so very big pseudotumor. Okay, and what is your clue? Your clue is the fact that you have previous radiographs that you can see, and the changes have started in 2012. Yeah, the next clue is the fact that it's low signal intensity rim around it. Yeah, it is heterogeneous, and it's just not obeying any plane, because it's just going through wherever it can find its way. It just goes into it, and then it starts destroying the adjacent bone where it is. Okay, so that, remember, he started with that on that side, but it was operated, and therefore it was not so catastrophic. We didn't see so many changes, so much osteolysis. Whereas this, he's left it, what, 2012 to 2021, nearly 10 years, 8 years, 9 years. Yeah, so it has had enough time to grow and then slowly eat the bones. So the other thing that this case demonstrates is why it's important to recognize these findings, because yes, it's not cancer, but it's as destructive as cancer and as morbid as cancer for the patients, because it's just destroyed the whole bone there. Okay, so they have, I think, and you can you see this black stuff that you get? That's because it's the reaction of the to the metal, and it's like a hypersensitive reaction. So even in the bone, they get really this gooey black stuff that's replacing the bone. So yeah, so review previous imaging, low signal intensity on stir. So you could see this before. So this was, in the previous imaging, it was there. So if it is a tumor that's been there for, 10 years, it would have grown at a faster rate, and it would have destroyed, more of the bone. Yeah. And it won't have, if it is like, what kind of tumor are you looking? Are you looking for a bone tumor? Then it will grow into the bone. Why will it have so many, soft tissue component to it? So I think those things will make you confident saying that this is a pseudotumor, likely to be related to the prosthesis, and unlikely to be a de novo malignant lesion that is arising from the soft tissue or from the bones. Okay. So one of the things I thought was, Overinterpretation, when you go back to this, I know it looks very drastic, especially this radiograph, but use first principles. Use the fact that you have, previous radiographs to go with, you have serial changes, and that will help you, make the diagnosis. And other first principles is, the fact that it's low signal intensity, and it is heterogeneous, but it's going in different directions. And there is a, the zone of transition. If you look at it, you have normal marrow adjacent to this abnormal marrow. It's not like when you get tumors, you get a broad zone of transition. Okay, that you won't get here, because it is a narrow zone of transition, because where the normal marrow stops and the abnormal marrow is there. Okay, so overinterpretation. So we say in karate, like, small focus sprints are most effective. So, just go for what is necessary, and not many, no doing CT, MR, every test that you need. Yeah. So take home points. I know the general feeling is, really plain films, but I think plain films are the answer. That's where you have it. Always review previous imaging. Okay, don't forget that. May it be for, any kind of your practice, previous imaging is important. Limitation of imaging, like, if you have poly wear, then MR is unlikely to be helpful. Plain film will give you the answer. The other case, I mean, only this Wednesday we had a case of subsidence, like, where you can see on serial radiographs that the prosthesis is going down slightly. Yeah, that is more than enough to say it is loosening. Okay, you don't need, loads of other tests, because that is like, you cannot have the processes moving. It shouldn't just move. I mean, it will subside a little bit, but you have quite significant subsidence, then that is a clue enough. And again, that is because you have plain films and you have previous imaging that you can compare it with. Okay, MDT discussions are very helpful, and I especially, like I said, we learn a lot. A microbiologist also attends that meeting, and it's like a proper MDT approach to try and treat these. And yeah, please do think about pseudotumor, think about osteolysis, think about the T1. T1 is your friend. T1, sequences. So please use, all those tools that you have, and don't forget plain films, plain films, plain films, plain films. Okay, and the other thing I just wanted to share, Dr. Khan, with your permission, was about the core MSK radiology webinars that will be happening on Tuesdays. So it's first, third, and fourth. If you want to do the second Tuesday, it's like just specialist lectures for skeletal radiology. So please join. If we want, this is all free. It's all free, and it's with the intention to try and share knowledge, and improve our understanding of MSK radiology. So thank you for that. So I will stop sharing my screen.
Thank you very much, Priya. Absolutely brilliant. I learned a lot, and it's fascinating to be learning after so many years. So every day we learn something new, and today I did learn quite a few things. So thank you very much.
Thank you. I mean, I think, like you say, every day is a school day. So
Yeah, definitely, definitely.
yeah. So
So yeah, over to you, please. Yeah.
I was just seeing, are there any questions that people have? Or?
Can you read the chat, or should I read it for you?
I think I have written cement and less, cement and cementless on image, please. Okay, what is the diagnosis? I lost connection. Uh, red pointer, they said. I didn't see, sorry. Was it clear? Like, I think I started drawing after that. So,
Yeah, yeah, that's good. Mm.
so I think Dr. Nafis, is there a particular case that you wanted? Okay, so do you biopsy these cases? No, I mean, because like I said, if it is around the processes and you have, evidence of previous imaging showing that there is osteolysis, then we discuss with the, hip surgeons, the arthroplasty surgeons specifically, and they take them to theater. So we don't, you know, do that. Is osteolysis similar to particle disease? I mean, yes, they are, like I said, so you can have either osteolysis like bony changes, or you can have in the soft tissue like pseudotumors. Yeah. So it'll be good. So struggle using no, just mention pointer. Okay. Ceramic and metal head. So I think we have gone through that. Osteolysis caused by and stress shielding. Stress shielding, wishing will not progress. You will see it on the first, and then it may actually improve. That's it. Whereas osteolysis on serial radiographs, it will become more and more lucent and bigger. So that's how you will do. Uh, Cement versus non-cement. So I think we have seen that this one. Let me go back. Cemented versus non-cemented. You wanted to see that again. So let me show this. And you said to use the pointer also. So I'll try and just do that. So share uh, window. Okay, and then I need it. So can you see this pointer? So this is the cemented one. Is this better, Dr. Khan? The pointer? So, and this is there's no cement at all. Okay, and this is the lucency that we were saying that you have. So I was trying to draw with this. I'll just see highlighter, a pen. So I was trying to show you that this is the line that you see. This lucency here. There's a lucent line that you can see here also. See. I'm drawing along the lucent line, yeah. So that's what you see and that's normal. Okay. If that increases, this is increasing, then that's when it's abnormal. So this will be on the post-operative itself. You should be able to see that, and sometimes it may take 1 or 2 days, but usually they do post-operative few days later. And this is only 2 millimeter wide that you see. So this is non-cemented. Okay, and this is a cement. You see the cement? So this here, you know, this whole thing is the cement. This thing here, from here to here, this here. Okay, so this is the cemented part. So this is the cement, this is the cement. And sometimes they have like a stopper so that the cement doesn't leak any further. Okay, so this is cement. So you can see the cement here as well. Okay, so that's cement. Okay, so Dr. Khan, was there any other specific thing they wanted?
I
My
think that
problem?
is it. That is it, please.
Yeah, that's the thing. Yeah.
Mm.
Okay, fine. So thank you.
So Priya, thank you very much. And your any parting comments you want to say, and then you can say goodbye.
Yeah. No, I mean, having knowledge about processes is not only, like I said, for daily practice, but it can be also asked, in exam practice and in both vivas and things like that. So they can ask them that as well. So hip is the main one of the main processes we see in daily practice. So that's why I focused on the hip. Shoulder is coming now. Quite a lot of shoulder. Our shoulder surgeons were saying the curve is going quite vertical with the numbers. But I think hip and knee are the main ones that people will see. So if they're able to identify that, that will be good. Maybe next time I can try and touch the knee complications. So thanks a lot, Dr. Khan.
Thank you very much. Thank you. It was such a nice lecture. So
Thank you,
thank you very much.
thank you. So I will take my leave now, and once again, congratulations, Dr. Khan.
Thank you very much. Thank you. Right. So before I start the Viva session, I cannot see candidate two. Candidate two, are you there? I can see candidate one. Uh, so one quick announcement once again, which I did last time also, that I think today the 2A result has also come. So there will be more registrars, UK-based registrars who are now in what I call the 2B world. So don't miss this course. Actually, these are two courses at UKIO 2026 on Monday, 8 June and Tuesday, 9 June. Of course, these are face-to-face courses. So the first course is all kinds of MR for FRCR, and the second one is a Viva course where you will have opportunity to attend 10 Vivas during the day as an observer, or if you want to volunteer as a candidate. So they're very uniquely designed, very intensive, but you will gain a lot. So don't miss it. And you can go to the website, and of course, this is a QR code which will also take you there. So let me now switch to the Viva. So candidate one, are you with us?
Good evening, sir.
Good evening.
Can you hear me, sir?
Yes, I can hear you. Okay, candidate two is here, and I will make you a co-host also. Just bear with me. Right, so we've got two candidates. I'll show you 6 cases, three to each candidate, my usual format. Right. Candidate one, can you see the image?
Yes, sir. This is a CT brain image which I can see.
Yes, yes. So this is a 35-year-old GP patient. Patient has headache off and on. They had asked for a CT. Over to you.
So this is, I've been provided with NCCT sections of the brain of a 35-year-old male patient with off and on headaches. So I'm not able to scroll.
Can you ask for the mouse?
Uh, so to ask for the mouse, I have to click on the.
Candidate two, do you know how to ask mouse for a mouse?
Yes, Dr. Kant.
So can you please explain to candidate one?
So you go to the top of the screen, you will see Dr. Khan's teaching as a
Yep.
tab. So you just click the three dots and then you
Yep.
should.
So I'm not getting the option. I'm getting
So
a new
just go to the
desktop.
top of the screen
Yep.
and do you see that Dr. Khan teaching screen as being shared? Can you see that tab?
Yeah. Yeah.
Yes.
Yeah.
Yeah.
Sorry for the delay, sir. I've asked for the.
I've approved it. Okay, over to you.
So I have been provided with a NCCT a brain of a 35-year-old male presenting with off and on headaches. I am scrolling from the caudal to the cranial end. On the first scroll, I'm not able to pick anything significant. However, while scrolling back, I see that there is some uh, hyperdensity noted in the left high frontal region. Uh, Also, there is effacement of the sulcal spaces in this region. Um, there's no area of infarction seen. There is no obvious interparenchymal hemorrhage. The ventricles appear normal. There is no hydrocephalus seen. So coming back to the area of concern, I also appreciate that there is a linear hyperdensity in the sulcal space in the left high frontal region. Could represent subarachnoid hemorrhage.
That linear density which you have pointed out, disregard it. Yeah.
Um, so can I also have the bony window, because in the left high frontal region
Yeah,
I
don't
also
worry
see the
about this. This is just
osteo.
something I'm not interested, something in the scalp. So there is no subarachnoid hemorrhage. I just wanted to highlight that. Don't worry about that.
There's no crowding at the foramen of magnum also. Um, so can I have a another orthogonal view, like a coronal window?
Why?
I just wanted to look for the same finding on the coronal window, the hyperdensity which I can see in
Why
the.
do you want to, what will you gain from that? Where is this placed, this opacity, density?
Within the cortex, within the
Right.
left
So it
high
is in
front.
the cortex. Coronal is irrelevant.
So this is a cortical hyperdensity in the left frontal high frontal region, and there is no surrounding edema noted. There's no vasogenic edema seen. Um, uh, there is no history of trauma, so this won't be a contusion. Um, This could represent a hemorrhagic met, but there is no surrounding vasogenic edema, so I'll rule that out also. Um,
So what else can it be?
I can appreciate that the density is also there in a few lower cuts, and it is still in the cortical region in the gray matter itself.
Yeah, so what else can it be?
So it's a hyperdense thing, so I would consider hemorrhage and as one of my top differentials.
What is the density of hemorrhage on a
Around
CT?
50 to 60 ounce per unit.
So this was in 40s.
Could represent a vascular malformation like a AVM, and I would want to do a post-contrast sequence angiography to look for any AVM.
So actually that was done, a post-contrast was done and it did not enhance.
Yeah. So that rules out an AVM. Then the next step should be MRI to further characterize this lesion.
Okay. MRI.
I've requested for the remote controls.
Yeah.
So I've been provided with a flare sequence, and I'll just scroll from the caudal to the cranial aspect and focus in the region of interest. So there is no evidence of any high signal intensity in that region, and there is no altered signal intensity seen in the area on a flare sequence. Uh, however, I'll just retract my statement. There is a um, hyperdense lesion with a hyperintense lesion with surrounding a hypointense rim, and this is giving a typical appearance of that of a popcorn-like appearance, and this could represent a cavernoma. I'll just scroll through the rest of the brain parenchyma to see if any other such lesion is there. No, I cannot appreciate any other such lesion. So my top differential will be cavernoma for this case. I'll convey my findings to the referring clinician and will refer this patient to the neurosurgery MDT.
Will you confirm this on other sequences?
GRE, susceptibility weighted imaging will confirm.
So what are you expecting on a susceptibility weighted image?
I'll be expecting again hypointensity and blooming,
Mm-hmm.
and a T2 will also show a hemosiderin rim around it. So similar appearance will be there on a T2 weighted image.
Okay, just hold on. Don't move your mouse.
And so this is an axial T2 weighted image, which is more characteristic popcorn-like appearance, where there is a central hyperintensity and there is a classical peripheral hypointense rim around it. And
This hypointense rim is because of what?
uh, it is due to hemosiderin.
Can this be a tumor?
Um, Unlikely, because I do not appreciate any vasogenic edema. I am not able to see any mass effect, although such a small tumor won't cause a mass effect, but there is no sulcal effacement. and there is no surrounding edema. So tumor is less likely.
Do covernomas enhance with contrast?
No, no, sir.
Okay, thank you.
Yes.
So this case is a covernoma. Now, covernomas can, it all depends how big is the covernoma. And on a CT scan, covernomas, usually small covernomas, you won't even see them. And you won't even see small covernomas on uh, all sequences of MR. You will have to see it on a susceptibility weighted image. But cavernoma can be high density also, like our case here. They can be high density also. Now, in this particular case, it is high density. One thing is that this was actually in the parietal lobe, and which was clear uh, on what we call the MR. Now, uh, I showed you a flare sequence. Now, uh, you should have asked for a T2 because T2 is a better sequence to see a covernoma. This kind of a covernoma. Otherwise, you did very well. Described it as a classical popcorn lesion. So in covernomas, what happens is that there is a peripheral hemosiderin rim. And this hemosiderin rim is continuous. A continuous hemosiderin rim is a very, very good news because, in covernomas or chronic hematomas, etc., when you find a continuous hemosiderin rim, that cannot be a tumor. Now, in the central portion of the covernoma, you can have a popcorn covernoma, you can have various kinds of signal intensities. And you can also have a high T1 weighted in the center. This particular case was not actually you, this is where it is. This is where it is on a sagittal T1. It was not very high. On a SWI sequence, it is showing blooming. So one feedback is that in the differential, you should have moved quickly, number one. And number two is that you should have asked for MR, which, think like this, that in a usual practice, what you do, and you ask for an MR, and take it further. So don't waste time there, or in asking the next modality. Otherwise, you have done very well. Okay, next case. Female, 79 years old. She has dysphagia and weight loss. Uh, Patient cannot cooperate. They tried an OJD, could not do it. Now, because of the time factor, I just want you to look at the esophagus.
Sure, sir. This is a contrast-enhanced CT image of a 75-year-old female who is presenting with dysphagia. Um, I'll just scroll through the sequences, and while uh, scrolling from cranial to caudally, I can see that there is a homogeneously enhancing soft tissue density mass lesion, uh, which is arising in the esophagus, in the mid thoracic esophagus, and it is causing complete near total luminal narrowing. Um, the mass lesion is associated with mild esophageal dilatation at the level of the mass and superior to the mass. Uh, it is closely abutting the trachea anteriorly, and it is also seen abutting the arch of aorta on the left lateral aspect. However, there is no obvious. The fat planes appear to be lost with the aorta. Considering she's a 75-year-old female, my primary diagnosis differential will be a esophageal carcinoma. I'll also want to view this in a sagittal section for further anatomical characterization.
How will the sagittal section help you?
I just want to confirm whether this is a solitary, well-defined mass which is within the lumen, or whether it's more like a eccentrical thickening which has completely occluded the lumen. On the axial plane, it looks to be like a solid mass rather than circumferential thickening.
Okay, don't move your mouse. So just concentrate on the finding, nothing else.
Um, yeah.
Let me make it bigger for you. Just hold on. Yeah.
So this appears to be a solitarily homogeneously enhancing mass region, which is completely occluding the lumen of the esophagus. And my primary differential will be that of a esophageal leiomyoma. Um, and I'll be conveying my findings to the referring clinician, and this patient will need endoscopic biopsy of the mass region.
So the patient could not have an OJD, could not cooperate. What else can you do?
Um, we can perform a PET-CT to look for any tracer uptake in case of neoplastic etiologies like carcinoma, whereas solitary leiomyoma of the esophagus won't show any uptake.
Something more simple?
And MRI, contrast enhanced MRI.
Anything else?
Conventional upper GI scan, a barium swallow.
So, yeah, over to you.
So these are dynamic sequences of the upper GI study, where I can appreciate that the contrast.
Hold on. Yeah. Now carry on.
Yeah. So I can appreciate that the contrast is filling the esophagus. There is no pent up or holding up of the contrast, and there is an eccentric, well-defined filling defect in the mid-thoracic esophagus, and there is no irregularity seen. And this is classical of a benign etiology. And I'll be keeping my top differential of esophageal pneumonia.
What else can it be?
It could have been a lipoma, but however on CT it shows homogeneous contrast enhancement.
Anything else?
Mm, In benign etiology, these are the top two differentials in my mind.
Can it be malignant?
No, because there is no ragged edges, there is no irregular mucosal irregularity, there is no holdup of contrast scheme. Malignancy is less likely.
Okay, thank you. Yeah, so this was intraluminal mass within the esophagus. Now, intraluminal mass, intramural, I wanted to say intramural.
Yes.
Intramural means a mass which is arising within the wall of the esophagus. Now, in the wall of the esophagus, the differential diagnosis will include, you were absolutely spot on with leiomyoma, which is fine. You also mentioned lipoma, which is fine, and you disregarded it because it was not fat density. But other than that, GIST uh, is there, and then neurogenic tumors, they can be there. Of course, intramural masses can also be malignant. That's the main thing. Now, to see if it is arising from the wall or is it compressing, sagittal is not a very good idea. And axial is the best sequence. One can see that this mass is there and it is causing compression. So it is very difficult to diagnose more than that. Just a bit of lumen is seen, proximal to the mass. Now, bariums, please remember that bariums do come in the exam still. And the current generation, your generation, you are now not doing bariums, so your eyes are not trained for bariums. So this is a barium swallow examination, which gives us a very good, addition to whatever we have learned. When you are describing barium, in the end, you did mention when I asked you why isn't it malignant, but you must say if there is mucosal destruction or not. That should be, a key point in your description. Otherwise, your description was spot on. We can see that the mass is here. It is causing luminal narrowing. However, there is no holdup, and then there is the mucosa is very smooth. There is no destruction of mucosa in keeping with a benign lesion. The only thing is that in the differential diagnosis, other than leiomyoma, GIST, nerve sheath tumors, lipomas, of course, you did rule it out. So these are the common ones. And of course, carcinoma can be focal also. So that, but this one on the solo. So solo was very helpful in this regard. Okay, well done. Now, next case.
So,
So this is a 29-year-old patient infertility type of a scan. So they want to rule out any structural abnormality. The main clinical history is infertility.
yes. So this is a young female coming with the complaints of infertility, and this is a T2 weighted MRI sequence, sagittal section, which has been provided to me. I'll just be scrolling from one end to another. The uterus is anteverted, and um, the endomyometric junction zone appears normal. The query is for any structural abnormality. The uterus on the sagittal section seems to be normal to me. Um, Just looking at the bilateral adnexa, bilateral ovaries with dominant follicles are normally seen bilaterally. Mm, Just looking at the spine ones, spine appears to be normal. Can I have a axial section for better characterization of the uterus? Scrolling through the axial section. Sorry for the lag, it's lagging a bit.
You cannot move it.
No, sir. Now it moves. Um, so, what appears to be a arcuate type of
So don't worry
morphology.
about the uterus. It might be arcuate. You are right. So don't worry about that.
Um, the uterus appears to be normal to me. There is no intramural lesion, no fibroids, no mass lesion seen. I'll focus on the adnexa now. Um, in the adnexa, in one of the ovarian uh, cyst follicles, there is a blood fluid level noted, a fluid level noted on T2, and this could represent a endometriotic cyst. Um, on the right side, there is a curvilinear hyperintense fluid containing cystic area in the right adnexa. Um, However, it is not leading up to the uterus, so this is not a hydrocephalus. Mhm. Any other complaints except for infertility?
No. Silence is not allowed in the exam. Why have you
Uh,
become silent?
I'm not able to appreciate anything
So you can ask for
striking.
something else. Or
Uh,
you have
yeah,
pointed out in the left adnexa, you pointed out something in your day-to-day reporting. If you are suspicious of something which has got hemorrhage, how do
yeah.
you confirm it?
I'll want to see the T1 weighted axial sequence.
So just hold on.
Yeah, on T1 weighted image, the left ovarian follicle, the cyst which showed fluid, the blood fluid level shows hyperintensity on T1 weighted sequence, suggesting hemorrhagic component within. And this will be classical of endometriotic cyst. So, summarizing my findings, left ovary has a cyst which has a T1 hyperintensity and a blood fluid level on T2 weighted sequence, which is classical of endometriotic cyst. Um, and I'll be conveying my findings to the referring physician and would refer this patient to the gynecology MDT for further management.
So what is the optimal sequence to diagnose hemorrhage?
Uh, for hemorrhage, will be a susceptibility weighted image.
No, 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 no. It
Yeah,
is it is a T1 and fat sat. So this is the lesion which you were pointing out, right?
Yes.
And there is something on the right side also.
Yeah, similar lesion is there in the right ovary.
So how is the shape of this thing?
A bit curvilinear. Um,
So what can it
uh,
be?
it could be the fallopian tube with hematosalpinx within.
And this is
The,
the other
the
side.
right adnexa, the tubular structure which I was pointing previously, also shows hyperintensity within. And this also is suggestive of hydrosalpinx.
Hydro or hemato?
Hematosalpinx.
How can you confirm this? What can you advise?
Again, this will be a transvaginal ultrasonography can be done to confirm this. However, on MRI, T1 fat sat sequence will be good enough for confirmation of
Oh,
blood products.
what I mean is that you have diagnosed bilateral cystic lesions, hemorrhagic lesions in the adnexa. And now you are worried that these might be hepatosalpinx, bilateral. So have you diagnosed the reason of the patient being infertile?
A patient having hematosalpinx will have infertility because it is a cause of infertility.
How can you confirm this?
We can confirm this on a hysterosalpingography. Yeah, this is a spot image of a hysterosalpingography where I can see that there is a dilated bilateral fallopian tubes with no free spill in the peritoneum bilaterally, suggesting there is a tubal obstruction bilaterally, um, uh, which is the cause of the infertility.
Okay, thank you. So, you have done very well, but what my observation is that you are shy to ask for the next thing, right? So, and your mind should keep working,
Yes, sir.
and you cannot be quiet in the exam. And ask for the next sequence, next, keep thinking that what uh, can be there. Otherwise, you have done very well. Okay.
So it's, I was trying to look for more findings in the same sequence, I think.
Oh, so you cannot do that. That is an absolute, you cannot do that. If in the exam you are quiet, you are
Yes.
gone.
Yes.
Uh, you don't have time, and number one. Number two, keep telling the examiner what you are seeing. You have to talk through the exam. I am looking at the Adinexa, I am looking for any other cyst, whatever, but you keep a running commentary going on. You cannot, if you are quiet, you will become extremely, first of all, you will lose your time, and number two is that you will become very tense also. And
Yes.
oh, you will go into a panic mode. Oh, I'm not able to see something. And
Yes.
there, a panic mode is that in this case, you should have, once you have picked up something on the T2 weighted sequence, the shape of that thing was the main thing. And number one, and then you should have asked for a T1. And this is the region where you became absolutely quiet. So that is the main thing which you have to work on. Otherwise, you did extremely well. Well done.
Thank you so
Okay.
much.
Now, let me go through this case, and this case is a good learning case for all of you. In your day-to-day reporting, there are subtle findings of endometriosis, deep pelvic endometriosis. So, endometriosis, this is a very good case for subtle findings. You already know that we have diagnosed hematosalpinx bilaterally. Uh, but there are other subtle findings, particularly for your day-to-day reporting. You must see them. Please remember when a patient comes for rule out endometriosis, that might be the clinical. At times, in this particular case, nobody knew that the patient has got endometriosis, but the patient presented with what we call infertility. Now, one of the key things here is that if you see, this is the peritoneum. This is the peritoneum lining, this is the cul-de-sac, and it goes and attaches to the rectum. On a sagittal sequence, trace it to both sides. So I'm going to one side. As I'm going to one side, you can see here peritoneum, and this, look at this is thickened. So this is a plaque of endometriosis with an adhesive band. Now, once you pick it up, you can then convince yourself that on the serosal surface, there is more low signal intensity focus. So there will be fibrosis, there can be punctate high signal also, and low signal also. So on the serosal surface of the uterus. So that was that finding is there. Now keep going and see if it is going to the, you see this thing? It is all thickened. It goes to the ovary, close to that. It goes close to this cystic lesion. Now these are ovarian cyst, and this one, if you see convoluted uh, what we call appearance of this, configuration of this. So it looks like a tube. And this was a key finding to be picked up. Now, if I am going to the other side, as soon as I go to the other parasagittal, you can again see plaques of endometriosis. Please remember that in clinical practice, what happens is that there are cases of endometriosis which they can diagnose on laparoscopy, but we don't see on MR. And why don't we see? Because we have not developed our eyes to pick up these subtle findings. So, and then here you can convince yourself that this plaque is actually adherent to the ovary also. Here again, if you look carefully, this was a finger-like, convoluted type of an lesion. Now, whenever you see deep pelvic endometriosis or endometrioma, then also see in the same go the thickness of the junctional zone. Is there adenomyosis or not? In this case, there was no adenomyosis. After this, I showed you the T2 weighted sequence. Now, on the T2 weighted sequence, again, this is the ovary. So we have got follicles or small cyst, and this thing is something extra. And now, if you see carefully, see this convoluted outline. Here, the candidate picked up, some fluid level, which ultimately was due to hemorrhage. And on the other side, again, there was this structure here, and it was much better visualized as far as the convolution is concerned on the sagittal. But even here, you can see that it is linear, and then it becomes more dilated. So hysterosalpingogram, again, they can ask you in the exam, and they will ask you more questions on hysterosalpingogram, like technique and etc. Though the gynae people do it, but they can ask you, some what kind of regarding the apparatus and things like that. Now, the candidate did very well where mentioned an arcuate uterus. Now, what is an arcuate uterus? If you Google it and try to differentiate between arcuate and septate uterus, just Google it and go to images and see the difference between an arcuate and a septate uterus. Key point to remember, and this is for your day-to-day practice, that whenever there is a gynae scan for abnormalities, as in structural abnormality, infertility, or at times they will pick it up on ultrasound and they will ask for MR. and they will say, please confirm whether this is arcuate or septate. So in septate uterus, there can be a spectrum, and this spectrum can, just Google it now, and you can see a picture. You can see that there will be a septa between the two endometrial cavities. Now, the key thing is technique to do the MR. Now, on this T2 weighted sequence, you can, if you are experienced, you can see that, this is a single cavity and something is going right and left. But this is a very subjective type of a finding. You should have a special coronal sequence, which was not done in this case. And I'll explain to you. This is for your day-to-day reporting. Here, you can see the two horns here, and they are joining. Actually, technique-wise, and you have to tell your radiographers about this, in this, you need to have a special coronal sequence. And the special coronal sequence should be along the long axis of the uterus. So it should be oriented like this. It should be oriented like this, long segment, which was not done in this case. So actually, we recalled the patient for that because they were asking, is it a septate or a, and in this axis, then you will see it very well. I don't think so. What I've told you right now is for your exam, but for your day-to-day practice, remember that. And then we did a hysterosalpingogram on which you can see, actually the arcuate uterus you can also suggest here, isn't it? But you can see the tube and you can see the hemato part. There is no spillage and there is no spillage here. Many of you might not have seen or done an hystero, but please remember they still come in the exam. And they do them in clinical practice also. Remember that. Okay, candidate one, well done. Candidate two,
Hello, sir.
yes. So, this is a 48-year-old male who has got upper, lumbar, very pinpoint pain, acute pain in the lumbar spine. On examination, there is tenderness in upper lumbar spine. There is no sciatica, no cauda equina, no bladder dysfunction. So the patient has got a lot of pain. Over to you. The mouse is with you, please.
Okay, so I've been presented with patient who has pain and has pinpoint pain, but no sciatica or red flag symptoms. So these are desagittal T2 weighted images. I'll just scroll through the images first to see if I can pick up any obvious findings on the scan. So the parasagittal images, I can see that there is some degenerative changes underlying. Not okay. I can see that the nerve roots are exiting nerve roots seem to be intact. There are some on both sides, and the spinal cord also ends in its normal position. I'm not seeing any obvious mass, but I can see that there appears to be some thickening of the cauda equina along.
Don't worry. That's just because of the position. So don't worry about the nerve roots or the cord or the thecal cell.
Okay.
Anything happening in the vertebral bodies?
So in the vertebral bodies, I can see that there are some degenerative changes with some altered signal intensities.
Okay, just 1 second,
I would.
please. I've given you a stir sequence. Over to you.
Okay, so on the stir sequence, I can. I think in the there's no obvious bone marrow signal abnormality, but I think I can see that in the anterior to the spine, there appears to be some abnormal signal. I'm not sure if this is the aorta, which is showing some
No, I'm not
heterogeneity.
interested in the aorta. Look at the vertebral bodies.
So in the vertebral bodies, there are in the lower corner of the um, upper lumbar or vertebra, I can
Okay,
see
the
that there is.
L2. What is L? Is there any finding in L2?
So there is a high signal intensity within the disk space with some underlying bony irregularity of the superior end plate. Uh, if this patient has presented with any fever or any other constitutional symptoms, then I would be suspecting some kind of spondylodiscitis. Otherwise, it could just be a small snode. Um, I would also like to look at the T1 weighted images as well.
So, okay, T1.
So on the T1 weighted images, there is um, there is low signal in the superior end plate. And this could represent some spondylodiscitis, or it could be a small snode. I don't see any obvious collections anywhere else in the spine. So I think this could just be an acute small snode in this patient.
How will you confirm this? What will you do?
Um, So first I would like to ask if the patient has any if there are any constitutional symptoms, if there's anything mentioned in the clinical history.
I have
Um,
told you the history. What else will you can do imaging wise?
we can look at the post contrast images.
Mm-hmm. Post contrast.
So on the post contrast, there is no significant. There is some enhancement in the upper in the region of the disc, and adjacent to this in the
Is there enhancement in
herniated.
the vertebral body also?
There is it is seen in the region of the herniated disc in the superior end plate. So I think this is an acute small snode which the patient has causing pain and symptoms.
What is an acute tumoral node?
So it's when there is herniation of the disc into the superior and superior and inferior end plate due to small fissures in the bone, causing the disc to be herniated.
So why is there enhancement going on?
Okay. So other differentials could be that it is a case of spondylodiscitis and its early phase. Um, I would I would correlate with any CRP or inflammatory markers if or any raised white blood
What
cell
is your
count.
final conclusion?
So
What will you
let-
advise?
um, so my final conclusion is I would like to look at any X-ray as well to correlate for this finding.
I am asking you conclusion. At this point, you can ask
Okay.
for it. Give me the conclusion.
So I think conclusion is that this is likely an acute Schmoll's node causing the pain, and other differential would be a spondylodiscitis. I have to correlate with the constitutional symptoms for the patient.
Okay, thank you. So interestingly, your diagnosis was correct, but your concepts are not. And this is an acute Chamorro's node. First of all, if uh, in acute Chamorro's node, please remember that Chamorro's node, by definition, according to the new nomenclature, this new nomenclature is going on since now 2003, but many people still call them Chamorro's node. By definition, they should be called intravertebral disc herniation. And we know that intravertebral disc herniation is a very common finding. It's an incidental finding, usually of no significance. What happens is that at the end plate, there is a point of, weak point where the disc herniates inside. Usually, it's a very, very benign condition. A patient can have many intravertebral disc herniations and things like that. One thing for the exams which you must remember is Scheuermann's disease, in which they are what we call adolescent kyphosis, where there are too many of them. But that's a totally different clinical scenario. And that will be in adolescent age group. Now, in this particular case, I provided stir. Now, on the stir sequence, we can see that there is edema at the superior, around the superior end plate. We can see this. And there is some high signal on the stir sequence. Now, for marrow imaging, the key sequences are stir and T1. When you find anything high signal on stir sequence, ask for a T1. So on a T1 weighted sequence, we can see that this is low signal. And I've told you many times that this low signal should be lower than the intervertebral disc. This is the formula in spine. And in other parts of MSK, the low signal of the bone should be lower than the muscles. So low signal on T1, high on stir means problems. Now, of course, there is an entity, we call it mod exchange. So, but in this particular case, the patient is symptomatic, and has got, the symptoms which I highlighted. Now, on Chamorro's node do not enhance. Usual Chamorro node do not enhance. But the pathophysiology of acute Chamorro's node, remember like this, that acute Chamorro's node is a different pathological entity. In acute Chamorro's node, what happens is that acute intravertebral disc herniation, which produces an inflammatory response. And that response, when you give contrast, it will enhance. So the bone marrow is enhancing here and the disc is enhancing there. So the key thing in this particular case was the confidence that this is acute Chamorro's node and not spondylodiscitis. Please remember that these patients, at times, the enhancement might continue for months and months. So that doesn't change everything. So you did well, but a bit of confusion because of contrast. So this concept you have to, because if you give this kind of a report, however, spondylodiscitis cannot be ruled out, they will start antibiotics for the patient. Okay, thank you. Now, your next case. This is a 85-year-old. The patient has got loss of weight, also has got dysphagia, and they did a chest X-ray. Over to you.
Okay, so this is a chest radiograph, frontal projection of a patient who presented with dysphagia and weight loss. So I can see that the gastric bubble is not visualized. I think this is an erect X-ray, and I can also see that there appears to be a fluid level which is seen at the lower cervical region, which could suggest
Here is the fluid level. Point it out to me.
uh,
Yeah,
this level here.
this is the trachea, isn't it?
Okay. Um, okay, so I was suspicious of this fluid level as a fluid level. Um, um, but apart from this, I'm not able to see the gastric bubble, which makes me suspicious of still that this could be an achalasia, which in the presentation could be due to carcinoma, which is causing a pseudoachalasia kind of a picture. And I'm otherwise in rest of the abdomen in the X-ray, I'm not seeing any obvious nodules in the lung fields, and the breast
Any other
shadows are.
finding in the mediastinum? Any other finding?
In the mediastinum, I can see that there appears to be a tubular kind of shadow, and the aorta is also not okay. I think the aortic shadow is seen, but there is in the right side of the mediastinum in the upper
Point it
and
out to me.
teens, this opacity.
Mm-hmm.
It appears to be suspicious for a distended esophagus.
Right.
Um,
What will
and
you do next?
I would like to do a CT of the chest and abdomen to further characterize the abnormality.
So forget about the abdomen. Just go through the chest, please. Over to you.
Okay, so I've been provided with a CT of the chest. Okay, axial sections. So I can see that there is significant distension of the esophagus with motile lucencies suggesting debris or food content within the lumen. I can see that in the region of the mid level of esophagus, there appears to be a soft tissue thickening, which is slightly irregular, which is causing an abrupt distension above this level in the subcarinal region, posterior to the left atrium. And there is also an enhancing lymph node on the left side of the lesion on the left side, just below the left inferior pulmonary vein. This is suspicious for a malignant process in this patient. The lesion is not causing any obvious invasion of the underlying left atrium. I can see that the fat planes are still maintained. The lesion is also in close proximity to the descending thoracic aorta, although it is less than 90 degrees, so it's still not, it's still abutting but not invading the aorta. I would also like to look at the chest, to look at the lung fields as well, to look for any aspiration or any lung nodules which could be um metastatic or due to aspiration. I would also like to look at rest of the abdomen and rest of the bones. Okay, so the lung fields, I'll just take a moment to scroll. I'm trying to look for any dependent opacities in the posterior aspects of the lungs to suggest any aspiration. There is a mosaic attenuation, but no obvious opacities.
Okay, conclusion.
So in conclusion, this is likely representing malignant neoplasm of the esophagus causing pseudoachalasia. So this would require urgent referral under a two-week wait pathway to the upper GI MDT for further discussion and management, and a possible endoscopic biopsy can also be done in
Okay,
recommend.
thank you. Thank you. Very well done. Well done. So in this particular case, I was so happy. Candidate immediately picked up something, and because of that, he immediately went on the right track, which was that there was no bubble here. Now, if you look carefully, uh, eh, I had to do a bit of prompting here, but maybe you had seen the finding and you could have described it. Now, first of all, this was not a level. This is the trachea. There is some, small amount of air here, which is outside the trachea. But having said that, this is a definite finding, which was correctly pointed out by the candidate. Now, if you see here, this is the aorta and this goes here. Now, on the other hand, we have got a second opacity. So this is the superior vena cava, and there is a line also in it. And this was the main finding, that it is distended. There is no gas bubble. So spot on, well done. And this was pseudoachalasia. Now, as far as the CT is concerned, a bit of fine touch regarding the local, which I'll tell you. Otherwise, again, it was well described. So if we go all the way here, we are, this is the level of, this is the cricoid cartilage, and there is fluid here, and it was very well done because I wanted to see that the candidate must point out that if there is any aspiration, and there was none in this case. But I wanted to see that. Now, if you can see, and you can see how it goes to the right side, and I'll show you a coronal just to highlight that. As we are going, now this is the left main bronchus. As we are going posteriorly, we can see this lesion. Now, and there is a lymph node here. Now, this thing here is a, if you see here, anterior displacement of the left atrium. On a CT scan, you can see it is anteriorly displaced by the mass. On a CT scan, this is taken as a sign of pericardial invasion. Remember that our sensitivity is not as good as EUS, but on a CT scan, if you see this sign, you can call it. Please remember, if pericardium is invaded, it still is a T4A tumor, actually technically still operable. But having said that, this CT sign should be pointed out. Now, second thing is the fine touch about the aorta. Now, if you see here in this region, in this region where, the contact between the tumor and the aorta is less than 90, which was correctly identified, but it is more than 45. More than 90 is a definite invasion or encasement. Between 45 and 90, doubtful. So the best way to deal with it is that you again advise a endoscopic ultrasound. And please remember, in this particular case, it might be irrelevant, but endoscopic ultrasound will tell you. So the fine touch is that it is in the gray area zone in this case. So these are two fine points. Otherwise, you did very well. and particularly happy that you also asked for the lung windows for aspiration. And just to develop your eyes, I'm showing you the, look at this esophagus, and this how it goes to the other side, and still there is no aspiration. We have got a chest X-ray later on, I think a few days or something, which is also a potential exam case. In this case, what happened was, uh, you can see effusions here. And again, the same finding, but now it is more blatant. So this is I think a few days or week after that X-ray. Here you can see it again. You can see this lucency here. This is the trachea. You can see this lucency. You can see how it is. Okay, well done. Now we go to last case of the day. Okay, candidate two. This is a 47-year-old GP outpatient patient, chronic headache. Over to you. Mouse is with you.
Okay, so this is a 47-year-old patient who has a chronic headache. So I'll just take a moment to scroll through the set of images before I start describing. I'll go through the entire stack of images. I'm not seeing any definite abnormalities, so I'll have to look at the review areas. I can see that there is some prominent extraaxial spaces in the bilateral frontal regions. In this, I'm suspecting if there is a subdural hematoma or a hygroma in this patient. I would like to look at other orthogonal views as well to confirm this finding.
Don't worry about this, nothing like that.
Um, so apart from this, I'm also trying to look at the foramen magnum. There's no crowding of the foramen magnum. I will look at the bilateral. Okay, so I can see that there appears to be some hyperdensity of the left sigmoid sinus focally, but I'm not sure if it is present. I
Again,
think even
don't
the
worry. Don't worry about this. Don't worry.
Okay, so my other review area would also include the cerebellopontine angles. So I'm just trying to look if, okay, so I can see that there appears to be bilateral densities which appear to be hyperdense in the region of the cerebellopontine angles, especially on the right side, which is slightly expanding the internal acoustic meatus. I would like to look at the bone window images to confirm this finding.
So nothing on bone window. Don't worry about the CP angles.
Okay. Okay, so otherwise I can see that there's no obvious hyperdensities of the common carotid or the internal jugular veins on the base of skull. Um, I can see that there appears to be diffuse low density of the brain parenchyma. But I think the gray white matter is still maintained. Yeah, I can see that the gray matter is maintained as compared to the white matter. So I don't think there is any loss of gray white matter differentiation.
Okay,
Uh,
you are
I'm coming
right.
back to
There
the
is gray white matter differentiation is intact, but review the parenchyma once again, please.
okay. So so coming back to the parenchyma, I can I can see that the splenium of the corpus callosum appears to be slightly and thickened. I would
Don't worry.
also.
Don't worry.
Okay.
Don't worry about it.
Okay, so I'm trying to look for any focal hypodensities or any sulcal hyperdensities to rule out any SAH, and also to look for any. Okay, I can see that in the right frontoparietal region there appears to be some asymmetry as compared to the left side.
Where? Point it out, please.
In this region, here in this region. It appears to be slightly asymmetric compared to the left side, and also the even posteriorly as well, as compared to the left side. It appears to be there appears to be some ill definition. I would like to know the age of the patient as well. If it's an old age, this could represent underlying
I told you the age. It was 47.
47. Yes. So this could represent an underlying white matter disease, which could be causing this abnormality. So I would like to suggest for an MRI to further delineate